All right. We're going to talk here a little bit about follow up on our first talk on pediatric emergencies and look at specific types of pediatric emergencies, starting first with medical emergencies. And of course, probably one of the more common medical emergencies that you're going to come across in a pediatric patient is going to have to do with a breathing problem. Uh, the vast majority of all cardiac arrests in children are respiratory in nature. After that, we're looking at maybe trauma. So I think it's important that in assessing a pediatric patient who's having trouble breathing, that you try to figure out whether you're dealing with an upper airway obstruction or perhaps a lower airway problem. Upper airway problems include things like epiglottitis or croup, a foreign body airway obstruction, and are clearly identifiable if you can hear stridor. Stridor is an inspiratory noise. Lower airway problems could include things like lower airway obstruction, which you clearly know you're dealing with if you can hear wheezing. Wheezing equals lower airway obstruction or bronchoconstriction, where rhonchi or crackles or gurgling in the lungs would indicate perhaps lung tissue disease like pneumonia, those sort of things. Now, care for the upper airway obstruction is different than care for the lower airway problems. And it's important that since we know the vast majority of all pediatric arrests are related to a breathing problem, if we recognize that they are having trouble breathing, we need to intervene quickly so that they don't go into respiratory failure. Children compensate very well. They have healthy hearts, healthy lungs, as a general rule, those sort of things. So they will compensate very well. But at some point, their compensatory mechanisms will fail and they will quickly plummet into respiratory failure and respiratory arrest and then cardiac arrest. So there's a number of diseases that range from the less serious, like a common cold, to a life-threatening respiratory problem like epiglottitis that we will see in children that lead to difficulty breathing. And so your role is to recognize that this child is in respiratory distress and treat it before it advances to respiratory failure. Now, when differentiating upper airway problems from lower airway problems, just remember that the upper airway starts from the larynx and works its way up. So it includes the larynx, the throat, the mouth, things like foreign body airway obstructions, particularly the tongue in an unconscious child, trauma, swelling from burns, infections like croup or epiglottitis. And again, you can commonly identify upper airway problems in kids because they're going to have difficulty breathing. You may hear that inspiratory noise that sounds like a gasp, or if they cough, they might have like a seal-like barky cough, like oh, or the inspiratory noise of stridor, like and that would certainly lead you to believe you're dealing with an upper airway obstruction. They may have difficulty speaking. If they're old enough to talk and they can only speak in one or two word sentences, that would indicate that they are severely short of breath. Now, lower airway disorders, they affect the large and small bronchial tubes and the alveoli. They include things like asthma, pneumonia, pneumonitis, and other respiratory infections. And typically lower airway obstruction you'll identify because as you listen to lung sounds, you'll hear a wheeze. Now, wheezing is a high-pitched whistle that is typically heard on expiration. Stridor is an inspiratory noise. Wheezing is an expiratory noise. Doing a patient assessment to determine whether or not a child has respiratory difficulty, if their breathing is drawing your attention, then you know that they're having trouble breathing. But you want to look for things like nasal flaring, which they flare much sooner than we do. Their nares are not near as stiff. The cartilage in their nose isn't near as stiff as ours. So they easily get nasal flaring when they start tugging and working hard to breathe. You're looking for intercostal retractions, use of abdominal muscles. You might hear noises like stridor, wheezing. Now, grunting is something that a child will do, typically on expiration, and it's their way of providing themselves with positive end expiratory pressure, or what we call PEEP. By grunting against a closed glottis as they exhale, they stent their little airways open so that gas exchange can take place. When breathing rates are greater than 60 breaths a minute, if their mental status is altered, that's where I start to draw the line between respiratory distress and respiratory failure. The brain is the first organ to show dysfunction when your body can no longer compensate and deliver oxygen to all parts of your body. So if you've got a kid who's working hard to breathe and you note that their mental status is altered, they're in respiratory failure. And if we don't act quickly, they will go into respiratory arrest. You may see a slowing or an irregular respiratory rate. They may have cyanosis, both peripherally, their fingers, their toes, their lips, or centrally on their trunk. They may have decreased muscle tone. You may not be able to palpate brachial or pedal pulses. And hypoxia, as a child becomes hypoxic, their heart rate has a tendency to slow down, not speed up. And if their heart rate gets less than 60 and they've got altered mental status, then we need to be doing chest compressions on those kids. Now, croup is typically a viral thing that you may see in children. They usually have a mild low-grade temp. They may have some hoarseness during the daytime, but at night they develop a loud, seal-like barky cough. They may have some trouble breathing. They may be restlessness, pale, or cyanotic. In most cases, because croup occurs at night, that's going to be your indication that you're dealing with croup as opposed to something like epiglottitis. Oftentimes taking the child outside in a cool environment or providing them cool mist humidification to breathe in, it decreases the swelling in their upper airway and it allows them to breathe easier. Now, epiglottitis is a sudden thing that comes on with a high fever. The epiglottis swells, usually the result of, a viral infection. Because their epiglottis is swollen, it hurts to swallow. So children will often sit up because they can't lie flat, because they can't breathe, and they'll be drooling heavily. It hurts to swallow, so they just don't swallow. They just let the drool run right out of their mouth. The patient will sit very still, because any sort of movement, makes the pain worse, and they're just going to look sicker than a child who has croup. When you're caring for a child who has a fever, you want to remove the child's clothing, cover in a towel soaked in tepid water, so water that's about 100 degrees. We don't want cold water because we could make them shiver, and shivering would increase their temperature and defeat what we're trying to do. So use a tepid bath to help bring their temperature down. If they start to shiver, then you're going to have to cover them with a blanket to help them warm back up. Follow the protocols for water or ice chips. In some children, they certainly may be really thirsty, particularly if they're dehydrated, and giving them water, sips of water, or certainly ice chips may make them feel better, but you have to make certain that they aren't going to be throwing that up later. Otherwise, it increases their risk of aspiration. Sometimes children will have a seizure with a temperature. It's not how high the temperature is, it's how quick it gets there. So if a child has a sudden spike in their body temperature and it shoots up quickly to 100, 101, or 102, that may be enough to make some children have seizures. They're called febrile seizures because the child is febrile. They are with fever. Um, we don't want to submerge those folks in cold water. We don't want to use rubbing alcohol to cool the patient. The whole thing with rubbing alcohol is it rapidly evaporates. So if I rub a person down with rubbing alcohol, as it rapidly evaporates and dries out the skin, it pulls with it a tremendous amount of heat. So, it might be good for lowering the temperature quickly, but again, if you lower it too quick, you can make them hypothermic. They can begin to shiver, and you can actually make matters worse. Children will have encephalitis, meningitis, could be bacterial or viral in nature. They're often going to complain of a really stiff neck. They're unable to touch their chin to their chest because the meninges are inflamed. And when you touch your chin to your chest, you stretch the meninges, causing pain. You want to give them high percentage of oxygen. You want to ventilate them if they're not ventilating adequately on their own. Certainly if they're unresponsive, even with a pulse, if their pulse is less than 60 and they're unresponsive, you want to provide CPR. Understand that these children may have seizures, particularly if their temperature is high, and transport them immediately. Another very common pediatric disorder is vomiting and diarrhea. Vomiting and diarrhea quickly will lead to dehydration in children, and when a child gets dehydrated or dries out, their brain just does not function. Brains just don't function well when they're dry. So if the patient has had a lot of diarrhea and vomiting and hasn't been taking much in, they can get severely dehydrated. To treat that, you want to open their airway. You want to provide them oxygen if their condition merits it. You want to contact medical control if the patient is showing any signs of shock. If a protocol allows you to do so, in a dehydrated patient who's been doing lots of vomiting or diarrhea, you certainly could give them ice chips to chew on, or maybe even a little something to sip. Just be alert that if they've been vomiting a lot and you put something in their stomach, even ice chips, it could cause them to vomit. If the child has a seizure in your presence, if it's a tonic-clonic grand mal type of seizure where you've got the muscles get very stiff and then there's a rhythmic jerking that occurs with that, which may include some tongue biting, some incontinence of urine or stool. In that case, you want to protect them initially, make sure there's nothing that they can hurt themselves on as they're having their seizure. But when it's done, roll them over onto their side so that they can drain, and they don't risk aspirating that. You may have to give them oxygen and then assess their breathing to make sure that it's adequate. If not, make sure that you provide adequate respiratory rates and depths. Children with an altered mental status, there are so many things it possibly could be. It could be trauma, could be shock, could be poisoning. They may be new onset diabetes, or they've never actually been diagnosed with diabetes. So any patient with an altered mental status, regardless of age, if you have the ability, we're going to get a blood glucose measurement. If the patient has suffered from poisoning, you want to contact your medical director, or the state would request that we contact poison control. Not that our medical director isn't well versed in maybe some more common standard sort of overdoses, but the person that has the latest and the greatest information concerning poisoning is going to be your poison control center. So you want to give them a call, because they may request that you mix up some activated charcoal and administer that. Now, we don't have activated charcoal in the Iowa protocol. We took it out years ago just because the risk of giving it, outweighs any benefit you might get from giving it. The biggest risk when giving somebody lots of activated charcoal is that they're going to vomit. And if they aspirate that vomit, it could cause a aspirate pneumonia that could kill them within hours. So you want to provide oxygen if that's what the patient condition needs, transport them, and continue to monitor their responsiveness. In an unresponsive child, we treat them initially, like regardless of what the problem is, by making sure the airway is open, making sure that you suction any sort of secretions or things that might be obstructing their airway. Get that tongue up off the back of the throat, measure their pulse oximetry, give them some oxygen if it's indicated. And if they're not breathing at an adequate rate and depth, and remember that children do breathe faster than we do. So if they're not breathing at an adequate rate and depth, then we need to provide artificial ventilation and either tier with ALS or transport. Unresponsive patients, oftentimes we're not sure how they got that way. So we need to try to rule out trauma as a cause of their unresponsiveness. In dealing with a child who is drowned, our biggest problem with drowning is hypoxia. And the sooner that we can provide artificial ventilation, the better it's going to be for the patient. So if we've got a patient who is drowned and is still underwater upon our arrival, as soon as the child is located and brought to the surface, you should begin doing mouth-to-mouth or mouth-to-mask ventilation right away. If they are unresponsive and their pulse is less than 60 or they have no pulse, begin chest compressions, hook up an AED, and then take care of some housekeeping things like having suction available to protect their airway. If there's history of them diving into a small part of the water, if there's a history of them, riding a very violent water slide, you might want to consider spinal immobilization, but as a general rule, it's not a problem. They will get hypothermic. They're in, water where the temperature is typically in the 50s, low 60s, around the mid part of summer. So pulling them out of the water, the fact that they're wet, they can become hypothermic quickly. Treat any trauma that you may see, but most importantly, transport them to a facility or tier with ALS for this possible drowning patient. Now, SIDS, sudden infant death syndrome. This is the diagnosis that's given when you have a sudden death of a baby, and there is no acceptable reason why the baby died. On autopsy, there's just nothing that would indicate why this baby would die. Typically SIDS patients are found hours after they have died, and there really isn't anything that we can do for them. However, when dealing with a SIDS death, it's very challenging for you as an EMT when you have family members screaming at you to do something, to not begin resuscitation and put them in the truck and head to the hospital. But initially, you're going to want to treat them as you would any patient who's in cardiac arrest. You want to begin resuscitation unless there's rigor mortis, and give emotional support to the parents, because oftentimes they feel guilty that if they would have checked on them sooner, it's all their fault, that sort of thing. Did I put them back or put them on their belly? There's just a lot of survival guilt and guilt that goes along with this as well. We'll look now at some trauma emergencies in kids. The number one cause of death in children is trauma. In fact, ages 1 through 44, you're more likely to die from trauma than anything else. It can occur certainly in motor vehicle collisions where the child is unrestrained or not properly restrained in a child safety seat. They may suffer some head and neck trauma. Remember, they have a very large, heavy head, and the younger they are, their neck muscles and those sort of things aren't well developed. And so their head, bobbles around, and during a rapid deceleration in a motor vehicle collision, they could, even if they're properly restrained, suffer head or neck injuries. If the seatbelt's worn improperly, they can have abdominal and lower spinal cord injuries. If the child is struck by a vehicle while walking across the street or running out into the street, there's just such a wide variety of injuries that they could have. We used to, try to match up the bumper height to the child's height. It was interesting, 20 years ago, when there weren't a lot of SUVs on the road, children suffered a lot of lower extremity trauma if they were struck by a motor vehicle. But today, with bumpers being so much higher in the air, we're just seeing all kinds of injuries, whether it's head injuries or abdominal injuries with internal bleeding, or extremity injuries with long bone fractures. When you're dealing with pediatric patients, as we mentioned in part one, if you've got an adolescent patient that's been injured, understand that as an adolescent, they certainly are concerned about being grossly disfigured. They want to be part of their care, so you need to treat the adolescent with respect, allow them to be part of the care, and answer questions that you can. Now, children's heads are larger and heavier, so again, their head is propelled forward during a rapid deceleration, which could cause head and neck injuries. Respiratory arrest is common secondary to head injury because following a head injury, a child may not breathe at all, or they may be breathing so erratically that they do go into respiratory arrest. Now, their chest, as far as children's chests go, we mentioned that their respiratory muscles are less developed, so when their body calls for more oxygen and they need to increase their rate and depth of breathing, they'll do that. But the faster and harder they work to breathe, the less effective their breathing actually is. Their ribs are more elastic, so they may not break a rib, but certainly could damage organs below the ribs. And when you see a deformity on a child, think of what the structures underlying are, knowing that they too are more than likely injured. You're going to examine the child from toe to head to toe, depending on whether or not the child is awake, depending on the child's comfort level with you laying hands on them. But certainly with a head, younger children have the fontanelles. You want to assess those. If they're bulging, that could be a sign of a rise in pressure inside the head. Could be a sign of bleeding inside the head, where sunken fontanelles certainly could be the sign of volume loss or hypovolemia, those sort of things. Look in the eyes. Their pupils should be equal and reactive to light, just like adults. Examine their neck. Make sure the trachea is midline. Look for jugular vein distension. Look for things like neck stiffness, crepitus as you palpate. See if they're able to touch their chin to their chest. And if they can't because of pain, you have to suspect certainly a neck injury, but in a medical patient, that could be a sign of something like meningitis or encephalitis. Examine the chest for bruising, look for equal chest rise and fall, palpate for crepitus, look for signs of breathing difficulty. And remember, when examining the chest, there are so many things inside that chest in all ages, not just children, but in all ages. The concern with children is, of course, that everything is so close together. So, a larger patient, those structures are spread far apart over a greater distance. So when a large person gets kicked in one side of the abdomen, it may only damage one organ. But when a child is kicked in the abdomen, it certainly could have damaged multiple organs. You want to listen for breath sounds over all lung fields. But remember, with smaller children, when you're placing the stethoscope on their chest, it's going to be very difficult for you to determine whether or not you're hearing these sounds from the right side of the chest or the left side of their chest, because everything is so close together. So as you see here, this gentleman is got his stethoscope out there in the mid-axillary line. He's way out here in the perimeter listening for breath sounds, and that's kind of where you want to be. You want to look at the abdomen to see if they're doing some diaphragmatic breathing. Remember that the abdomen can be certainly a hidden site for serious life-threatening injuries where the patient may be bleeding into their belly. But just like adults, if they're bleeding into their belly, it will become distended, it'll become rigid, board-like, those sort of things. And remember, that's going to interfere with their ability to breathe as well because they are primarily belly breathers. You want to be alert for vomiting. And you also want to manage any sort of extremity injury in children just like you do adults. You're going to follow the basic cares of splinting. You're going to follow the basic care of controlling hemorrhage, those sort of things. You can examine the abdomen to look for bruising, tenderness, guarding, look for swelling that might indicate that they swallowed lots of air. And again, just like the chest, there are so many things in the abdomen that could be damaged, even with a blow to only one side or one quadrant of the abdomen in the child. You want to compress the pelvis, push the iliac crest together to see whether or not there's crepitus or some indication of a major pelvic fracture. We don't rock pelvises anymore, distract them. All those things could be detrimental. You want to examine each arm and each leg individually, looking for pulse, motor, and sensation. Work your way down each extremity, to determine whether or not there's a bone broken in those areas. And then finally, don't forget to roll them up onto their back and examine their back for decap BTLS. Now, the type of equipment that you use to immobilize children, could, if you've got large groups of children and a limited number of pediatric equipment, you could use a KED to function as a long spine board in kids. So here you can see the KED being used as a long spine board. Burns, you want to identify candidates that may be transported to a burn center. And typically, since we don't have burn centers, we have trauma centers. All our trauma centers will initially treat our burns as trauma, and then if necessary, transport them on to a major burn center. You want to cover the burn with a non-adherent sterile dressing. Saran wrap is certainly something that is highly recommended. It usually isn't sterile, but it is clear, it is clean, it keeps the heat in, keeps the bugs out, so it allows you to assess the injury without having to remove dressings or those sort of things. If they've breathed in superheated flames, they've got soot around their nose or mouth, you want to make sure that you assess their airway, that you suction is needed. Consider immobilizing the spine if they have those sort of problems. Now, I'm going to talk briefly about child abuse and neglect because as an EMS provider, you are a mandatory reporter of both child and dependent adult abuse. Now, there are a variety of different types of child abuse, and they often occur in combination of one plus another. Psychological abuse is one that is very difficult to prove. It has to be diagnosed by a clinician. Usually involves things like failure to thrive, a child who doesn't thrive in the environment that they're in. And then you've got neglect, and certainly neglect occurs in just a wide variety of degrees. Whether it be not providing adequate clothing or shelter or food for your children. Now, understand that these sort of things like psychological abuse, physical neglect, physical abuse, sexual abuse, if the perpetrator doesn't have the means to provide children certain things like trip to the dentist, trip to the ear doctor, eye doctor, those sort of things, and the children need those resources, it's not negligent of the caregiver to not provide them those resources, especially if she has no financial means. But what you can do as a provider is note that there was a need for these services and then make the report to the Department of Human Services, and they will investigate whether or not this is actually abuse or whether or not they just need access to resources. Now, as far as physical and sexual abuse goes in children, almost every imaginable kind of injury and maltreatment can occur as a result of this. Children who are beat on a regular basis are often called the battered child syndrome. It was first identified in the 1960s when radiologists were looking at bones of children only to find out that they had multiple fractures over time that were never ever reported. Sexual abuse ranges anywhere from adults exposing themselves to forcing sexual intercourse or to torture the children sexually. um, when we can see the abuse, like physical abuse, we can see the physical abuse, sexual abuse, we can be told about it, we certainly can see the signs of a struggle, those sort of things. But what's really hard to prove is the emotional abuse, because we don't see marks. We just see children who aren't developed properly. We see children with exaggerated startle responses. We see children who are afraid to say anything around their caregiver. Those sort of things that would indicate that we're dealing with that type of abuse. Some signs of possible physical abuse certainly are looking at physical injuries, slap marks, bite marks, bruises, cigarette burns, cuts, those sort of things, particularly in areas where children don't bruise. Multiple bruise in various stages of healing certainly is an indication of physical abuse. Broken bones, head injuries, abdominal injuries, bite marks, particularly to the inside of the thighs, around the genitalia, the buttocks, the small of the back. Now, oftentimes adults will tell you that bite their children for whatever reason, form of punishment. They'll often tell you that another child bit them or that a dog bit them. Now remember that when dogs bite people, they sink their teeth into the flesh and they shake their head back and forth and cause some serious looking wounds. We also can measure the distance between the incisors of a bite and know whether or not that bite came from a child, an adult, or a dog. Burn marks, look at the burn marks. Do they resemble something that was used, like a hot iron or a curling iron, or holding a hand or a finger over a flame? If a child has been shook and their head is flopped back and forth, they could have a severe brain bleed that certainly is going to lead to unconsciousness, blown pupils, seizures, all those sort of things from shaken baby syndrome. Now here certainly is an example of a child who is bruised. And what I want you to note here is that we have this color bruise, we have that color bruise, and they are multiple bruises in various stages of healing, and they are in areas where children do not bruise. Now, children certainly can have, things like a bleeding disorder that causes them to bruise easier, but that's going to be documented in their medical chart. And remember, when you're filing a report, you're not there to prove whether or not this is abuse. You're just reporting that you suspect it might be. It's the Department of Human Services' responsibility to prove whether or not it is. Now, here is a cord whip injury on a teenager. Again, if this were bite marks, we could tell based on the incisor marks as to whether or not this actually came from an adult, a dog, or a child. Signs of physical abuse, obvious signs that you can see. Signs of sexual abuse are going to be any unexplained genital injury, seminal fluid on the body or clothes, sexually transmitted disease, pregnancy. If the child tells you that they were sexually assaulted, that is, that's, as someone might say, money in the bank, because children rarely lie about that. It takes a tremendous amount of courage to call out your abuser because they fear certainly that they will be left alone. There'll be nobody to care for them. They'll break up the family. There's a variety of reasons that children think that. But if the child tells you they're being assaulted, whether it's physical, sexual, or otherwise, you need to report that. Possible indications for an adult being an abuser, or how do you know this adult is abusing this particular child you've been called upon to look at? Well, the adult may have inappropriate concern or may be smothering the child with affection. The adult may have a history of controlling their anger, They may appear to be under tremendous stress and on the brink of an emotional meltdown. They may suffer from mental illness or depression. They may increase their use of alcohol or drugs. They may have suicidal thoughts. When dealing with children that have been abused, you want to address and provide appropriate care, but preserve evidence if you can. Discourage the child from going to the bathroom, taking a shower, that sort of stuff. Give them nothing by mouth. Don't have the child wash or change clothes. If they do those things, if they clean themselves up, that sort of stuff, ask to see or collect the clothing they were wearing and bring that with you. So your role as an EMT when dealing with abuse or neglect is to gather the information without an expression of disbelief or judgment. It's important that you let them know that if you're gathering information to determine whether or not abuse has actually occurred, that you let them understand that that you're a mandatory reporter and that you're likely going to report this. You want to pull the child aside and talk to them separately with no parent around. Oftentimes they will limit what it is that they say when a parent or a caregiver is around. You want to speak to them in very plain and clear language. As far as medical staff, you want to be very clear of any finding or a suspicion of the infant or child having physical abuse or sexual abuse. And we throw the terms around suspected and possible, but remember that it is your responsibility to report that there's a problem. That is your role. It's the Department of Human Services role to determine whether or not it actually did occur. If it does occur, the abuser is automatically put on probation. The abuser may be I don't want to say discharged, but the abuser will be, if the investigation confirms that it was in fact abuse, the abuser will be placed on the central registry, which will be out there for a period of 10 years. At the end of 10 years, that information will come off the registry. If a parent in a possible child abuse case reveals suicidal ideology, obviously the parent needs help. So I think, as any prudent rescuer would do, you would look at getting help for that particular parent. We'll talk about infants and children with special challenges as well. Some of the common challenges that infants and children will have is premature infants may have issues with lung disease throughout their early development. Infants and children may have heart disease. They may have neurologic disease. There are certainly children that have strokes and then have, partial sighted paralysis, all those sort of things. Children also can have chronic diseases like diabetes, and they may also have altered function from birth. Tracheostomy tubes is certainly something that a child may have, and the issue with tracheostomy tubes is they can become obstructed. If they do become obstructed, then really what's important is that we assess their need for suction, assess their need for ventilation, and then if we can't relieve the obstruction, then we might be able to remove the tube and replace the tube or just breathe into the stoma. There is a very small baby there in the picture that has a tracheostomy. Some patients may be on artificial ventilators or home ventilators. If the ventilator is working properly, there will be no alarms or buzzing or anything like that. But if you're there to care for the patient and you move stuff around and it quits working properly, it's going to buzz, it's going to alarm, those sort of things. Just remember the worst case scenario is that if you have a patient who's on a home ventilator and you take them and for whatever reason during going down the road, they can no longer breathe or the ventilator is giving off all these errors, there's nothing to say that you can't disconnect the ventilator and assist their ventilations with bag valve mask. Central lines, implantable lines, those things do become infected, they bleed, the lines can be crimped, they can be cut off, but they, as a general rule, are relatively reliable for the first 4 or 5 years that they're in service, and then after that they really do need to be replaced. If you've got a central line that's been pulled out, a PICC line, that sort of stuff, you may have to apply pressure if there's bleeding, but then transport the patient for reinsertion of that particular line. Now here's a G-tube. G-tube is a gastrostomy tube for tube feedings. This might be certainly in a child who's unable to eat, and they would receive all their nutrition through the G-tube. Now, G-tubes can be pulled out of the abdomen as well. When they are, there may be a little blood with that, there may not. Certainly we can transport the patient with the G-tube out, where they can get them to a hospital where they'll just reinsert the G-tube. Be alert for altered mental status, open the airway, suction, provide oxygen, put them into a position where they're not likely to vomit or aspirate by rolling them up onto the right side. Shunts are something else that children may have. These are in the head of the child. Shunts occur as a result of not being able to drain their cerebrospinal fluid out of their head through their ventricles in their head. As a result of that, they'll put shunts in that will help drain the fluid into their abdomen, and there are times when those shunts can become occluded. So if the shunt is occluded, CSF is going to build up inside the head. It's not going to be able to get out of there, and it's going to cause very similar presentations that a brain tumor would cause, or a seizure would cause, or a head injury would cause. So you want to maintain an open airway. You want to ventilate them. You want to give CPR if they're unresponsive and their pulse is less than 60. You want to transport them, but let people know that you are in fact dealing with a malfunctioning shunt. As far as the EMT and pediatric emergencies go, there is a psychiatric effect on EMTs when you have a really bad P call. As EMS providers, we have a tendency to over-triage children. We try to do more things for them than perhaps what is necessary. We know that being on a pediatric call, those are extremely stressful. Especially in these small communities where we may know the children, they may be our children, nieces or nephews, that sort of stuff. So oftentimes the psychiatric approach or the psychiatric damage that you may undergo as a result of seeing a critically ill or injured child and nobody to care for them could be a big stressor. In dealing with stress with children, obviously the more training that you have in how to deal with children and their medical conditions, the more comfortable you'll feel with the dealing with them. But typically you want to typically in dealing with stress, as I mentioned with the first bullet point, it's something that you can learn to do with, but you've got to work at it. You've got to when you're taking care of a patient, particularly a pediatric patient, as we're talking about here, and the pediatric patient stresses you because they are seriously ill or injured. talking to the caregivers afterwards, talking to the patient afterwards, dealing with your own performance, all those sort of things kind of play into, well, how do you feel afterwards when it's done? When caring for children, the other thing to keep in mind is that we don't know a lot about what really works with kids. There's a handful of things where we've actually done some research. We know it works well. But as a general rule, we're going to take most of what we know about adults and apply that to children, particularly with EMS. You also can talk with other EMTs when you feel stressed. Talk to other people that you have a connection with, whether it be your pastor at church or a close friend, those sort of things. And should you have no resolution when talking to others about how this stressed you out, most services will offer some sort of an employee assistance program where you're allowed to talk to a mental health professional or counselor with a minimum of a master's degree who can help you understand why you're feeling the way you are and help you work through your stress. All right. So with that, that wraps up our talk on pediatric emergencies. I think it's important that as an EMT, we understand that children are not just small adults, and that while what we know about what works in children is limited, we still should strive for providing appropriate care using appropriate equipment for our pediatric patients. So again, if you have any questions, you know how to get a hold of me. So I'll be talking to you soon.